So welcome to the class. The topic of discussion is a Meigs syndrome. So this syndrome was first reported by Joe Vincent Meigs in 1937 in a series of 7 cases where patients presented with patients of ovarian fibroma found to have ascites and hydrothorax. And Meigs was the first to describe the resolution of ascites and pleural effusion after surgical removal of the tumor, and there was a benign post-operative course. So Meigs syndrome is characterized by benign ovarian tumor that presents with ascites and pleural effusion. The incidence is around 1% of ovarian tumor. Differentiating Meigs syndrome from malignant tumor is very important because that causes, because of ascites, hydrothorax, it causes a little difficulty in diagnosing whether this is a Meigs syndrome or we are dealing with malignancy, because Meigs is associated with benign ovarian tumor. Okay, so clinical features. Typically, it is seen in postmenopausal women with dyspnea, dry cough, and painful abdominal distension. On examination, there will be adnexal masses, diminished breath sounds, and signs of ascites will be there. When Meigs syndrome is diagnosed in young individual, we should think of a Gorlin syndrome, that is nothing but a familial cancer syndrome. Now, what are the diagnostic criteria for Meigs syndrome? They were established in 1954. Presence of benign ovarian tumor such as fibroma, thecoma, granular cell tumor, and Brenner tumor. Okay, but classically it is described with a fibroma. So if you have got an option, the first you will think option you will select as a fibroma. Okay, there is ascites, there is pleural effusion, and most important is the resolution of ascites and pleural effusion following tumor removal. Pericardial effusion is not included in the definition of Meigs syndrome. However, there have been case reports of patients with unexplained persistent pericardial effusion that has also resolved after the removal of the benign ovarian tumor. So, in the diagnostic features, we'll remember it is a benign ovarian tumor, ascites, pleural effusion, and these ascites and pleural effusion, there will be resolution after the surgical removal. Okay. So what is the differential diagnosis? Differential diagnosis will be ovarian malignancy. There can be hepatic cirrhosis or other non-gynecological malignancies like pancreas, gastrointestinal, or lung cancers, sometimes associated with ascites and hydrothorax. Then congestive cardiac failure, nephrotic syndrome, tuberculosis, and other differential diagnosis will also include pseudo-Meigs syndrome. Okay, where there is a ascites and pleural effusion in a patient with pelvic or abdominal tumor other than fibroma. So if it is tumor other than fibroma, we call it as a pseudo-Meigs syndrome. So other benign ovarian cysts such as struma ovari or mucinous cystadenoma or teratoma, uterine leiomyoma, and secondary metastatic ovarian tumors can cause pseudo-Meigs syndrome. Another syndrome is a differential diagnosis, that is Chalmers syndrome, which is also known as pseudo-Meigs syndrome, a clinical manifestation of SLE, that is systemic lupus erythematosus, which is characterized by the ascites, pleural effusion, and elevated CA125 levels in absence of ovarian tumor. Okay, so that is another differential diagnosis for Meigs syndrome. Now coming to the lab investigations. So lab investigations will be mainly required for as a workup for the preoperative purpose, as well as to rule out other underlying conditions, anemia, nephrotic syndrome, liver failure. So complete blood count, comprehensive metabolic panel, coagulation studies, brain natriuretic peptide, urine analysis, these all investigations are required. CA125 levels may be elevated, but they are not diagnostic of Meigs syndrome. Pelvic and adnexal imaging for diagnosis of adnexal masses we have to carry out. X-ray chest for pleural effusion and any other pulmonary nodule which is suspicious of malignancy, that will also exclude Meigs syndrome. Okay. Then other imaging such as CT of the chest, abdomen, pelvis, that will exclude differential diagnosis of ascites such as metastasis or masses originating from GIT, pulmonary lesions, and liver cirrhosis. So CT and CT chest, abdomen, pelvis will be required to rule out other malignancies. Okay. Then PET CT will be required to confirm the benign nature of the ovarian mass and determine whether the other malignant lesions are present or not. And other is a PET CT with FDG F18. That radio tracer performed 1 hour after the intravenous administration of 18-FDG shows mild uptake in the event of benign ovarian tumor. Whereas if it is a malignant mass, it will demonstrate higher 18F-FDG metabolism. Okay, so these are the investigations, that is the lab investigations, imaging modalities which are indicated in cases of Meigs syndrome. Then we also have to carry out fluid analysis, that thoracocentesis and paracentesis. It may be diagnostic as well as it may be helpful for relieving the symptoms of the patient. Okay, so pleural fluid can be analyzed for protein, lactate dehydrogenase, cytology, gram stain, and cultures. In most patients with Meigs syndrome, the pleural fluid is exudative and there will not be any malignant cells. Then tuberculosis screening, skin test you can do. Then pleural and peritoneal fluid testing for acid fast bacilli, smears and culture, and molecular testing for tuberculosis. So these are the tests which are required for or in cases of Meigs syndrome. Now coming to the treatment. Treatment can be curative treatment or it can be palliative treatment or symptomatic treatment. Now what is the curative treatment? It is the surgical removal of ovarian mass through laparotomy or through minimal invasive techniques such as laparoscopy, and intraoperative tissue sampling with frozen section is required. Okay, so if the patient is young and desiring fertility, then we may go ahead with a unilateral salpingo-oophorectomy. Okay, because it is a benign tumor, provided we carry out intraoperative frozen section analysis. Okay, then if it is a postmenopausal woman, then total abdominal hysterectomy with bilateral salpingo-oophorectomy is indicated. And removal of the tumor results in resolution of the ascites, pleural effusion, and normalization of CA125 in Meigs and pseudo-Meigs syndrome. Okay. Then symptomatic treatment, it is indicated for those patients who have medical comorbidities where the curative treatment you cannot carry out. So repeated large volume paracentesis or thoracocentesis are palliative choices for these patients. They can have abdominal indwelling peritoneal catheter placement, which allows patients or their caregivers to drain ascites as needed at home, is also another option. So abdominal indwelling peritoneal catheter can be put. And another is a repeated thoracocentesis. Here also you can put indwelling pleural catheter, and pleurodesis are the available therapeutic modalities for symptomatic management of pleural effusion. Okay, so treatment can be curative or it can be symptomatic. In symptomatic you can have paracentesis or you can have thoracocentesis, and curative will be depending upon the desire for the fertility and age of the patient. It can be unilateral salpingo-oophorectomy or you can go ahead with a total abdominal hysterectomy with bilateral salpingo-oophorectomy. Okay, so that finishes the topic of Meigs syndrome. Okay, thank you.